Normally, a diagnostic skin biopsy is actually incredibly linear. I mean, you find a suspect spot, take a sample, stitch it up, and a few weeks later, you just have a predictable little scar.
Right, it's standard procedure. The body usually knows exactly what to do.
Exactly. You're relying on this implicit trust that the local cells, the fibroblasts and macrophages, know exactly how to handle acute trauma. But when we look at the clinical guidelines for active lichen sclerosus, that whole predictable timeline just completely vanishes.
Oh, it goes completely out the window. You are no longer just managing a surgical wound at that point.
Right, you're looking at a tissue landscape where the standard rules of wound repair are just suspended. And a simple diagnostic cut can suddenly cascade into a chronic open ulcer.
Yeah, you're dealing with a highly compromised autoreactive ecosystem. I mean, lichen sclerosus alters the very architecture of the tissue, especially in the anogenital region.
Welcome to the deep dive. Today, we're taking you on a very specific, highly crucial mission. We've been looking through a stack of clinical guidelines, recent dermatology reviews, and patient accounts to answer one incredibly complex question.
And it's a question that clinicians struggle with constantly.
Definitely. We're asking, how do clinicians manage delayed wound healing, ulceration, or tissue dehiscence, which is when a wound bursts open following a diagnostic vulvar biopsy in active lichen sclerosus skin?
It's a massive challenge because the tissue is already so thinned out, discolored, and easily torn.
Okay, let's unpack this. Because right away, we hit a central paradox. To save the tissue, you have to cut the tissue. To rule out cancer, you have to sample it.
But the act of sampling it is what triggers the complication.
Exactly. What happens when that thin, inflamed skin just refuses to heal or breaks down into this painful ulcer?
It requires the clinician to act as a detective and, honestly, a master of wound care. To understand why it's failing, we have to look at the biopsy catalyst itself.
Right, so let's start there. What actually happens during the procedure?
Well, clinicians typically use what's called a Keyes punch. It's a cylindrical blade, usually about 3 to 5 millimeters in diameter.
So like a tiny apple core.
Basically, yeah. Or they do an excisional biopsy to remove the epidermis and dermis. Now, in healthy skin, normal healing takes anywhere from 1 to 8 weeks.
But active LS skin is highly compromised.
Severely compromised. The immune system is already attacking the area. You've got intense inflammation, loss of normal tissue architecture, and all these microfissures.
It's like trying to patch a pothole on a road that is actively crumbling during an earthquake. I mean, the foundation itself is just fundamentally unstable.
That is a perfect analogy. And it brings us to a fascinating concept from the sources, which is the Koebner phenomenon.
Right, the Koebner phenomenon. This blew my mind.
Yeah, it's wild. It's where physical trauma to the skin, like biopsy cut or even a circumcision scar, actually induces the disease to spread.
So the disease Koebnerizes right into the new scar tissue.
Exactly. The trauma acts as a biochemical catalyst. The scalpel cut causes cytokines to release, which is supposed to call in repair cells.
But instead, it calls in the immune system to attack.
Right. It aggressively recruits autoreactive T cells to the exact site of the injury, so it directly interferes with the body's natural healing process.
Which raises a huge red flag for me. If cutting the skin can make the disease attack that exact spot and completely prevent healing, why do the biopsy at all?
It's a fair question, but a biopsy is an absolute necessity if malignancy is suspected.
Because of the cancer risk.
Yeah. Lichen sclerosus carries about a 5% risk of progressing to squamous cell carcinoma or developing differentiated vulvar intraepithelial neoplasia, which we call DVIN.
Wow, okay, so missing that cancer would be catastrophic.
A fatal error.
Yeah.
So the clinician has to take the biopsy knowing full well that the surgical site is at incredibly high risk for dehiscence.
So the clinician performed the biopsy, and now the patient returns a few weeks later, and the wound has either opened up dehisced or turned into an actual ulcer.
And because of that Koebner phenomenon we talked about, the clinician can't just slap a bandage on it.
Right, they have to figure out why it's not healing. They have to do some detective work.
Exactly. They have to run through a differential diagnosis. The sources lay out very specific clinical thresholds here.
What are they looking for?
A non-healing ulcer could be a secondary infection, like cellulitis, or it could be an inflammatory mimic, like Behçet's disease or aphthous ulcers.
Or, worst case scenario, the ulcer itself is a malignancy.
Right. And differentiating between an autoimmune blockade from the LS and an active cancer requires meticulous observation.
Which brings us to Claire's story from the Royal College of Obstetricians and Gynecologists blog. Her experience is just so harrowing, but it perfectly illustrates how difficult this is.
It really does. Her case is a textbook example of visual mimicry in this region.
Yeah, so Claire had a perineal tear that just wouldn't heal. It eventually turned into a persistent ulcer, and initially it was misdiagnosed as herpes.
Which is common because they can look very similar clinically.
Right, but it wasn't herpes. It was actually DVN and vulvar cancer, operating in the background of this undiagnosed lichen sclerosus,
And because of that misdiagnosis, the wound was left to heal by secondary intention.
which means healing naturally without stitches, right?
Exactly. The tissue has to slowly granulate from the base of the wound, bed upwards, completely unassisted.
And for Claire, that took a massive amount of time. Plus, it was complicated by cellulitis and severe pelvic lymphedema. She lived with this chronic open vulnerability.
It highlights the absolute necessity of resolving a non-healing wound. But there's a huge catch-22 here for the clinicians.
Wait, yeah. If a post-biopsy ulcer isn't healing, and non-healing ulcers are a primary sign of cancer, do they have to biopsy the wound caused by the first biopsy?
What's fascinating here is how clinicians actually balance this. They don't want to just keep inflicting surgical trauma on a cauterized ulcer.
Because that would just make the healing even worse, I imagine.
Exactly. So they use a treat, watch, and wait approach. They utilize intensive local care to see if the wound shows any signs of healing.
But they can't wait forever.
No, clear biopsy thresholds keep the urgency proportionate. They don't want to cause panic, but any changing, persistent ulceration requires action. In the UK, for instance, it triggers an urgent suspected cancer referral within 2 weeks.
Okay, so while all this high-stakes diagnostic stuff is happening, the patient is still just sitting there with an open, agonizing wound in a highly sensitive area.
The day-to-day physical reality for the patient is brutal. The anogenital region is densely innervated.
And it's constantly subjected to friction and moisture. How is this physically managed?
Managing the pain and protecting the exposed dermis is the immediate priority.
The sources mention some really specific physical relief tactics, like tepid sitz baths 2 to 3 times daily.
Yes, to gently clear cellular debris without physical debridement, which would just traumatize the tissue more.
Right, and then patting the area dry instead of rubbing. They also talk about using a squeeze bottle of warm water during urination.
That's a crucial one. Urine is highly acidic, and when it hits exposed nerve endings, the pain is intense. The water dilutes the acidity in real time.
They also use topical lidocaine, like 2 to 5% ointment, applied directly to the margins for pain relief.
But the core of the wound care is the barrier method. You have to minimize irritants, so no soaps, no tight clothing.
Just bland barrier ointments, right? Like plain petrolatum, just regular Vaseline.
Exactly. It traps moisture, creating a hypoxic, moist environment. Keratinocytes, the cells that reepithelialize the wound, can only migrate across a moist surface.
If it dries out and scabs over, the healing just halts. But here's where it gets really interesting. We hit this ultimate medication paradox.
The steroid paradox. It's one of the trickiest parts of managing this condition.
Yeah, because the gold standard treatment for lichen sclerosus is ultra-potent topical steroids, like clobetasol propionate.
We rely on those steroids to suppress the T-cell autoimmune attack.
But do you put a super potent steroid directly into an open bleeding ulcer?
You really can't. Introducing a steroid there creates a massive biochemical conflict.
Because clobetasol aggressively shuts down local inflammation. But wait, isn't that initial inflammation biologically required for a wound to heal?
Exactly. Fibroblasts rely on those inflammatory signals to know when to migrate in and start building new collagen.
So if you use the steroid too early, you just paralyze the fibroblasts?
The LS might be suppressed, but the wound is biochemically frozen open.
Wow. So what is the protocol for threading that needle?
It relies on meticulous timing. The sources recommend a specific protocol post-surgery. If the area is significantly ulcerated, clinicians use plain Vaseline for about 2 weeks.
To allow the initial tissue closure to happen naturally.
Right, let the fibroblasts do their job. Then, once you have baseline structural integrity, you restart the clobetasol in a very thin film.
And this delicate dance of timing happens before the biopsy too, right?
Yes. If a biopsy is delayed, high-potency steroids can be used initially, but patients actually have to stop steroids for 3 weeks prior to a new biopsy.
Because otherwise it masks the histology.
Exactly. The pathologist might look at the tissue and think it's normal, completely missing the disease process operating underneath the steroid suppression.
It's just a constant shifting calculation. But what happens when that basic wound care and timed steroid protocol fails?
That's when we have to look at medical escalation. The tissue is dehisced, standard protocols aren't working, and the patient is in pain.
If the LS inflammation is physically blocking the wound from knitting together, the guidelines say clinicians might escalate to topical calcineurin inhibitors.
Right, medications like tacrolimus or pimecrolimus.
But wait, I noticed a really harsh reality in the sources about this. Tacrolimus is known to cause significant burning upon application.
It induces a profound neurochemical reaction, yes.
You're putting a cream that burns onto an open ulcer. That sounds agonizing for the patient.
It is a massive barrier to adherence. It triggers a huge release of substance P, which is a primary pain neurotransmitter, directly from the nerve fibers in the wound.
So how do they even get patients to tolerate it?
Clinicians recognize this, so they often start at lower doses, like 0.03%, and slowly increase frequency.
To kind of build up a tolerance?
Yes, to let the nerve endings gradually deplete their stores of substance P. Over a period of weeks, the burning diminishes.
Okay, but what if the wound is severe and completely refractory to those creams?
Then care is escalated to multidisciplinary teams. Dermatologists might get involved and introduce systemic immunosuppressants like methotrexate.
So treating the whole body's immune system to finally give the local tissue a chance to rest and close.
Exactly. And beyond pharmacology, we are seeing the introduction of regenerative therapies to speed up wound healing.
The cutting-edge stuff. The sources mentioned platelet-rich plasma, or PRP, and autologous fat grafting.
These are fascinating because they aggressively modify the local tissue environment.
Yeah, with fat grafting, they extract fat from the thigh or abdomen, which is rich in stem cells, and inject it into the vulvar tissue.
Those stem cells secrete cytokines that suppress inflammation and introduce new volume to the rigid mucosa.
And PRP works on a similar idea, right? Concentrating platelets from the patient's own blood.
Yes. When injected into the margins of the non-healing ulcer, the growth factors in PRP are hypothesized to promote rapid wound healing.
By signaling local cells to form new blood vessels, overriding that sluggish, ischemic environment.
If we connect this to the bigger picture, managing these complex wounds requires a truly holistic view.
It's not just about stopping the T cells or rebuilding blood vessels.
Right, you have to balance hormones, perhaps using topical estrogen to restore mucosal elasticity.
And treating secondary infections, like the cellulitis Claire faced.
And, crucially, providing profound emotional support.
Absolutely. The emotional toll of a debilitating chronic condition, compounded by an open wound and the fear of cancer, requires dedicated psychosexual counseling and pain management.
It demands an exceptional level of vigilance from the whole care team.
So what does this all mean? If you're a patient or a clinician navigating this, managing a non-healing biopsy wound in LS is essentially a high-stakes balancing act.
It really is.
You're constantly trying to rule out underlying cancers while simultaneously outsmarting that Koebner phenomenon.
And you have to meticulously time the use of ultra-potent steroids versus plain barrier ointments.
Right, while knowing exactly when to escalate to advanced therapies like tacrolimus, immunosuppressants, or even PRP.
Which leaves us with a really provocative thought to mull over.
Oh, I like where this is going.
Considering how incredibly dangerous physical trauma is to lichen sclerosus skin due to the Koebner phenomenon, you have to ask, how close are we to developing non-invasive, highly accurate imaging technologies?
Like being able to diagnose it without the scalpel at all.
Exactly. Perhaps advanced AI dermoscopy or molecular swabs that could definitively diagnose LS and rule out cancer.
That would change everything. You could confirm the diagnosis without ever having to make a single cut into that fragile ecosystem.
Bypassing the risk of a non-healing ulcer entirely. It's a very real horizon in dermatological care.
That is an amazing thought to end on. Thank you to everyone listening for joining us on this deep dive into the source material.
Yes, thank you for being here.
As you navigate this complex clinical landscape, or if someone you know is, we encourage you to keep asking questions, keep seeking out multidisciplinary specialists, and keep advocating for comprehensive, nuanced care. We'll catch you on the next deep dive.